Part A. In this part of the test, you will hear two different extracts. In each extract, a healthcare professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for extract 1. Extract 1. Questions 1 to 12.
Hello, doctor. Good morning.
Good morning. May I find out what the problem is?
I've been experiencing the symptoms of heart failure for the past year, doctor. Although it appears okay in general, I feel a lot of stress and fatigue. I've also noticed shortness of breath with exertion. I am getting attacks of severe shortness of breath and coughing that usually occurs while I'm sleeping. I have developed edema and had a mild leg swelling a while ago.
Do you have severe chest pain called angina, palpitations, or syncope?
No, doctor, but I feel some irregularity in my pulse. Over the past 10 months, these symptoms have been gradually worsening. Over the past year, I've gained about 20 kilograms in weight, doctor.
What's your age?
63, doctor.
Have you had any previous illnesses?
I had right inguinal hernia surgery 7 years ago. I had trauma to my right thumb.
Do you have diabetes, mellitus, or heart murmur?
No, doctor.
Do you smoke or drink?
I don't smoke, but I drink.
Tell me about your family history. Any illness?
My mother's alive at 92. My father died at 76 of a heart attack.
Are you taking any medications?
Yes, doctor. Aspirin, 81 milligrams daily, and chlordiazepoxide and clidinium combination pill at 5 milligrams or 2.5 milligrams, 1 tablet daily for stress.
Are you allergic to any medicines?
No, doctor.
Okay, well, according to my comprehensive cardiovascular examination, your blood pressure is 120/70 in each arm seated. Your pulse is 80 beats per minute and regular. Your breathing is 2 times per minute, and that is unlabored. Lungs are clear to auscultation and percussion. The first and second heart sounds are normal. You have a fourth heart sound and a soft systolic murmur. The precordial impulse is enlarged. Your electrocardiogram shows sinus rhythm with left ventricle hypertrophy. Your peak oxygen consumption was 19.7 milliliters per kilogram of body mass per minute, which is consistent with mild cardiopulmonary disease. Laboratory data shows your thyroid stimulating hormone 1.33. Your glucose is 97 and creatine 0.9. Potassium is 4.3. I reviewed your echocardiogram thoroughly. That shows a dilated cardiomyopathy with ejection fraction of 15%. Your post-stress ejection fraction is 33%, and left ventricular cavity appears enlarged. This appears to be a newly diagnosed dilated cardiomyopathy of uncertain etiology and dyslipidemia. I'm going to prescribe angiotensin-converting enzyme inhibitor lisinopril 2.5 milligrams daily and a beta blocker, carvedilol 3.125 milligrams twice daily. In addition, you could benefit from a loop diuretic, furosemide 20 milligram daily. I don't think you need a defibrillator right now, and after 3 months of medication, I want you to go on an echocardiogram. If your left ventricular function has not improved, then you would benefit from a prophylactic use of an implantable cardioverter defibrillator. So continue with these medications and meet me after a period of 3 months.
Thank you, doctor.
Extract 2. Questions 13 to 24.
Hello, good morning, doctor.
Good morning. Tell me, what's your problem?
Well, I have a history of first-degree atrioventricular block and had a pacemaker placement. I feel this problem of decreased eye vision. Last time the problem lasted for about 5 minutes. That occurred 4 weeks ago when I was driving the car.
Then how did you manage to drive?
Well, I was able to pull the car over to the side of the road without much trouble. During that time, I felt nauseated and lightheaded. When I approached the clinic at that time and received a CT scan, carotid Dopplers, echocardiogram, and neurological evaluation, all of which were unremarkable, I couldn't have an MRI due to the pacemaker placement.
Okay. Did that occur again?
No, doctor.
Any lesions or change in vision, headaches, change in gait, or other neurological issues?
No, doctor.
Do you have any back pain, bowel or bladder incontinence, or frank lower extremity weakness?
No, doctor.
What's your age?
57, doctor.
Do you drink or smoke?
I don't smoke, but I drink alcohol, only on some special occasions.
Any past illness or surgeries?
I had pacemaker placement for atrioventricular block, and I had bilateral knee replacement 3 years ago and have some pain in my knees.
What medications are you taking?
I have recently started on Plavix, suggested by primary care doctor. Other than that, baby aspirin, 81 milligrams per day, Proscar, 5 milligrams, GD, and Synthroid, 0.2 milligrams daily.
Are you allergic to any medication?
No, doctor.
Well, your physical examination shows your blood pressure at 134/80, your heart rate 60, respiratory rate 16, and weight is 244 pounds. Cranial nerves 2 through 12 are intact, and you have normal bulk and tone throughout. There's no cogwheeling. There is some minimal weakness at the R4 plus or 5, and possibly trace weakness at the quadriceps -5 or 5. You have decreased sensation to vibration and proprioception and vibration. There is no dysmetria or tremor noted. His Romberg is negative. You have developed transient ischemic attack. The character of his brief episode of visual loss is concerning for compromise of the posterior circulation. Differential diagnosis include hyperprofusion, stenosis, and dissection. You have lumbar stenosis. The symptoms are very mild and consist mainly of some mild proximal upper extremity weakness and very mild gait instability. You have to get a CT angiogram to evaluate the integrity of the cerebrovascular system.
This is the end of Part A. Now, look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete the answers as you listen to the audio. Now, look at the question 25.
Doctor, can you explain to me whether measuring serum amylase or serum lipase is significant for acute pancreatitis?
Well, measuring both serum lipase and serum amylase is not necessary. Measuring serum lipase alone is adequate for diagnosing acute pancreatitis, since it is more effective than serum amylase, especially because it rises more quickly and remains elevated longer. According to a study of 151 patients with acute pancreatitis, the sensitivity of lipase was about 97% and the specificity was almost 100%. Contrarily, the sensitivity of amylase was just 79% and the specificity was 99%. Therefore, amylase should be replaced by lipase as the first-line laboratory investigation for suspected acute pancreatitis.
Question 26.
Hello, doctor. What are uterine fibroids?
Well, uterine fibroids are benign tumors that may grow in various parts of the uterus of a woman. Intramural fibroids are the most common type of fibroid that appear within the muscular wall of the uterus. Intramural fibroids can grow larger and stretch the womb. Subserosal fibroids form on the outside of the uterus called the serosa, and may grow large enough to make the womb appear bigger on one side. Submucosal fibroids bulge into the uterine cavity. Pedunculated fibroids are attached to the uterine wall by a stalk-like growth called a peduncle, which is the main difference between pedunculated fibroids and other fibroids. If a pedunculated fibroid forms in the middle muscle layer or myometrium of the uterus, then it is called pedunculated submucosal fibroid. And if it forms outside the uterus, it is called the pedunculated subserosal fibroid.
Question 27.
Thimerosal is a mercury-based preservative that has been used for many decades in the U.S. in multi-dose vials of medicines and vaccines. There is no significant evidence of side effects caused by the mild doses of thimerosal in vaccines, except for minor reactions such as redness and swelling at the injected site. However, during 1999, the Public Health Service agencies, the American Academy of Pediatrics, and vaccine manufacturers agreed to reduce or eliminate thimerosal usage in vaccines as a precautionary measure. Methylmercury is obtained from certain kinds of fish. A high exposure to methylmercury can be toxic to people. However, over a lifetime, everybody is exposed to some methylmercury. Thimerosal contains ethylmercury, which is the most widely used form of organic mercury that is cleared from our body more quickly than methylmercury and is likely to cause any harm to the individuals.
Question 28.
Hello, doctor. Can you explain to me what is leukopenia disease?
Well, leukopenia is a condition where the patient has lesser white blood cells in their bloodstream, which is diagnosed with a blood test called a complete blood count. There are 5 types of white blood cells, and each of them protects the body from a different kind of infection. Neutrophils make up 55 to 70% of total white blood cells, and they fight off fungal and bacterial infections. Lymphocytes protect the body from viral infections. Monocytes are the largest of the white blood cells, and they fight against bacteria, fungi, and viruses, and they mend tissue damaged by inflammation. Basophils are involved in inflammatory reactions to allergens. Eosinophils fight parasites and play a role in allergic reactions and conditions, such as asthma.
Question 29.
Hello, doctor. What should parents do as peanuts have become an allergic substance nowadays?
It is really a very frightening factor to know that peanuts can cause allergic reactions, with increasing reports of sudden death in children following peanut ingestion, and new products are being launched on the market to help parents stave off a peanut allergy in their children. What I feel is feeding peanuts to children doesn't require any specialized products. Right now, we have the strongest evidence that kids are at high risk because they have a severe egg allergy or eczema, and the dietary guidelines suggest that infants with severe egg allergies or eczema should intake peanuts as early as their 6th month. What I feel is introducing peanuts to infants with moderate or mild eczema or egg allergies in a developmentally and culturally appropriate method would probably help prevent peanut allergies for the rest of their lifetime. Since peanut allergies are increasing rapidly, the early feeding strategy is something that the parents should consult with their pediatrician, as it is one of the best sources of protein.
Question 30.
The bony growths that develop on the finger joints are called Heberden's nodes, or interphalangeal joints. Mostly, Heberden's nodes develop on the joints nearest to the fingertips, causing the fingers to appear crooked. They only develop in osteoarthritis patients. Each joint in our body has a layer of cartilage to protect the bones. Osteoarthritis causes the cartilage layer to degrade, gradually allowing the bones in the joints contact directly with each other. Over time, the bones get damaged from scraping together. Our body reacts to this body damage by developing new bones that are known as nodes. Heberden's nodes are one of such bone formations on the fingers of patients with severe osteoarthritis.
This is the end of Part B. Now, look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You will hear an interview with a dietitian called Ben Melrose, who's talking about iodine deficiency. You now have 90 seconds to read questions 31 to 36. My guest today is a dietitian called Ben Melrose, and today we're going to be talking about iodine deficiency and some of the medical consequences of that. Ben, iodine is a trace element that's found in many foods. Why do some people not get enough?
Well, in some parts of the world, this is an endemic problem, and it's not a question of dietary choice. We get iodine from various sources, like there's iodine in eggs and dairy foods. But by far the biggest source is the ocean. Fish that live in salt water and plants that grow in that environment are our main source of iodine. So we see relatively few cases of deficiency in Europe, for example, because such foods are plentiful there. But elsewhere, typically in the middle of large continents, it's a different story. There, people simply don't have access to sources of natural iodine. Obviously, poorer people in those regions are most likely to suffer deficiencies, but everyone's affected to some degree.
And the consequences of iodine deficiency can be quite serious, I imagine.
Yes, classic symptoms are things like muscular weakness, not being able to focus on the task in hand, and also a tendency to feel cold, even in hot weather. But the most widely reported symptom is actually a feeling of constant tiredness.
Oh.
Of course, there are tests that can determine the level of iodine in the body, and 150 micrograms is regarded as the minimum daily intake needed to avoid symptoms. And there are related conditions. A typical one is an enlarged thyroid, what's often called a goiter.
So you've worked in South America then, where I think it's quite common to see patients with a goiter.
That's right. The case of one of my own patients illustrates this very well. Let's call her Mirabelle. Mirabelle's a middle-aged woman whose home is high up in the Andes Mountains. She lived in Europe for a number of years, where she enjoyed a varied diet and good health. When she and her husband went back to their native country, however, they returned to a remote region and tended to revert to the local cuisine, which is lacking in iodine. As they hadn't suffered any of the symptoms of iodine deficiency before they left for Europe, they didn't feel any particular need to worry about their diet now.
But I believe she developed a goiter.
Well, what happened was she started to have problems sleeping. She'd wake up in the middle of the night with discomfort in her legs, and then she started to get a sore throat. At first she assumed it was flu, but the symptoms persisted. Then one day she noticed a slight swelling on her neck. At first she couldn't believe it. The family were eating lots of river fish and fruit, so a diet that was healthy enough in many ways, but crucially lacking in iodine. Knowing this, she'd been taking multivitamins since her return, so was initially skeptical until a test confirmed that this was the cause.
So, were you able to help Mirabelle?
I was able to work out a diet for Mirabelle that made the most of the natural sources of iodine that were available to her. I also encouraged her to eat Brazil nuts. These are a good source of selenium, which actually helps the body to absorb the traces of iodine which are present in other foods.
Oh.
I also advised her to steer clear of certain processed foods, like bread made with flour improver, because these actually impede the body's ability to absorb iodine. I left it up to her whether or not she continued with the multivitamins.
So, what conclusions do you draw from Mirabelle's case?
What it made me think was that millions of people on this planet must be existing on the brink of iodine deficiency, and that's a cause for concern. Like Mirabelle, when you're young, the body can cope, but this takes its toll with time. Another thought I had was, did Mirabelle become more susceptible to the effects of iodine deficiency as a result of the iodine-rich diet she'd enjoyed in Europe? I couldn't say, but that certainly seems to warrant further study.
Questions 37 to 42. You will hear a plastic surgeon called Norma Woolston giving a presentation about surgical treatment for a condition called dupuytren's contracture. You now have 90 seconds to read questions 37 to 42. My name's Norma Woolston, and I'm talking today about surgery for a condition called dupuytren's contracture, with a particular reference to a case I treated recently. Dupuytren was first described by a French physician of that name in 1834. It's a condition in which one finger becomes increasingly bent in a flexed position. The first sign is a formation of small hard nodules in the palm of the hand, but early diagnosis is relatively unusual because there is no associated discomfort. In its early stages, the condition may respond to steroid injections and physical therapy, but this doesn't necessarily halt its progression. The affected finger often becomes increasingly bent and can no longer be straightened. But patients tend to present with the condition only when manual dexterity is compromised, by which time surgical intervention is indicated. My patient, let's call him Eric, presented with quite an advanced case of dupuytrens affecting the little finger of his right hand, a relatively common site for the condition, although a physical examination revealed that he was also developing the first signs in the thumb on the same hand. Eric was then a 61-year-old office worker who used a keyboard regularly. There isn't very much published so far on the causes of the condition or what might exacerbate the symptoms, but the digital age doesn't appear to have resulted in an exponential rise in the number of cases reported. Eric was finding the condition inconvenient and uncomfortable rather than painful. It was becoming tricky shaking hands with people, and holding a pencil was becoming a challenge. Eric didn't recall any family history of dupuytrens. That's not unusual, but doesn't in itself mean that there was none. Indeed, we know that the condition is often present across the generations of one family. But because patients don't typically develop symptoms until late middle age or later, it often goes undiagnosed or doesn't develop to the point where it requires treatment. Indeed, mild symptoms are often attributed to mild arthritis or the general effects of aging and wear and tear. Nor did Eric report any of the other associated risk factors, such as smoking, diabetes, or low body mass index. It's worth noting, however, that he was of classic Northern European appearance, tall and fair-skinned, and dupuytrens is known to be much more common amongst Northern Europeans than in other populations. In Eric's case, the condition had progressed to the point where surgery was indicated. It was clear to me that what was required was a fasciotomy to straighten the finger. Eric had some misgivings about this, as he'd heard about less invasive treatment options. But I explained to him that, taking into account the extent of development of the diseased tissue and the specific site, this was the only option, and he agreed to go ahead with the procedure. Fortunately, Eric was generally in good health, was taking no medications for other conditions, and had no concerns or negative history relating to general anaesthetic. This was much the preferred option because, although the surgery isn't lengthy, usually between 30 and 40 minutes, it does call for a complete immobilization of the hand. After the procedure, Eric was using a sling and pillows at night to hold the wound site high up and so prevent a build-up of fluids. I'd explained that wearing a sling when out and about also provides a degree of general protection. It's a remarkably effective way of signalling to other people to keep their distance, as the hand is very sensitive to knocks. But actually, he'd taken plenty of time off work, so this hadn't been a problem for him. Indeed, when I saw Eric at the follow-up appointment, the wound was healing well. His note showed, however, that the sutures hadn't all fully dissolved after surgery, and that this had been a source of discomfort. Worried that perhaps there was an infection, he'd consulted a nurse, who'd removed them and also taken the opportunity to excise some excess scar tissue, which had formed at the site. I reassured him that this was by no means unusual and wasn't a cause for concern. I was pleased to see that when he returned for the final consultation, Eric's wound had generally healed well. As is the case with many dupuytren's patients, however, Eric volunteered that, despite my careful explanation at our first consultation about the treatment and recuperation period, he'd entirely underestimated the impact of the surgery on his daily life and how long the disruption would continue. That said, his finger is now much straighter. This treatment for dupuytrens never completely straightens the finger, nor restores full use, but he'd been aware of that from the outset and had no complaints on that score. So far, apart from the initial indications in his thumb, there is no sign of recurrence, although this is relatively common, especially over time. I reflected, however, that perhaps being very familiar with the condition and having performed this kind of surgery many times, I hadn't made it clear enough to Eric exactly what to expect after the surgery. What Eric's case made me realise is